Now we will start HCC 6, Current Status of TACE and HAIC. The moderators for this session are Professor Shiro Miyayama, Professor Shuntaro Obi, and Professor Junwon Park. Moderators, please start.
Good afternoon, everyone. Welcome to Kyoto, and welcome to our session, HCC 6, Current Status of TACE and HAIC. So we have moderator Dr. Shiro Miyayama and John Won Park, Dr. John Won Park, and my name is Shuntaro Obi. And we have a discussant, Dr. Yamamoto Akira here. And we have 4 papers. And we have finally 10-minute discussion. So here we go. First presenter is Dr. Chadaura Ashok from India. Here? No? So Dr. Chadaura Ashok Chadaura absent. So we move next presenter. So next presenter is Dr. Nagamatsu Hiroaki from Japan. Dr. Nagamatsu, please.
Mouseがないですね。ここにあった。Thank you, Chairman. I thank for all concerned giving us an opportunity to make this presentation. I'll talk about new FP therapy for long-term prognosis in patients with unresectable HCC. We want to achieve complete cure, not like extension of several months for patients with advanced HCC. So we have been performing multidisciplinary treatment centered on UFP therapy. Moreover, it is important to make cancer-free treatment, including conversion therapy. This slide shows the way of implanting of reservoir system. The artery catheter was inserted from the femoral or brachial artery by the Selzinger method. The right gastric artery and the gastroduodenal artery were embolized using microcoils to prevent from gastroduodenal injury by anti-cancer agent. This is a method of new FP therapy. On the first day of the treatment, 50 mg of cisplatin with Lipido was injected through the reservoir catheter, followed by 250 mg 5-FU bolus injection. Then 1,250 mg of 5-FU was continuously infused with a balloon pump for 5 days. We confirmed the reservoir system by arteriography via the reservoir port. Then we injected cisplatin with Lipido via the reservoir port, watching arteriography for about 10 minutes. This is an APNT reported in 2010 about new FP. Response rate was 83%, MST was 33 months. There are few problems of new FP via the enduring reservoir system. Accurate embolization of gastrointestinal branches is required to prevent gastrointestinal ulcers. Long-term Reservoir placement increases complications such as both infection, hepatic artery injury, and decreased liver function. We have devised an easier and safer way to perform UFP therapy. This is a method of temporary injuring catheter system. We temporarily injure IT-type Armstrong PU catheter via the left brachial artery to hepatic artery and fix over the skin. We call it simple reservoir. Here are the advantages of simple reservoir. We do not need coil embolization to gastrointestinal artery. We can also easily treat the patient who have replacement hepatic artery. This is a method of UFP therapy using simple reservoir. Patients were treated with lipidolization of cisplatin 50 mg, followed by 5-FU 1250 mg via balloon pump for 3 days. After 3 days, we performed one more course in hospital, and then we leave off simple reservoir. We perform this method 3 to 5 at monthly interval. There are two main HIC regimens in Japan. We compared with two regimens. We compared with two group characteristics. UFP group patient conditions were worse than low-dose AFP patient. For example, tumor size and PVTT. In result, response rate, UFP was 71%, low-dose AFP was 39%. MST, UFP was 19 months, low-dose AFP was 14 months. There was significant difference in two groups. We consider UFP to be the best HIC regimen for advanced HCC. This slide shows changing peripheral blood concentration of total protein after UFP. At the peak of total protein concentration, the case of lipid mixture cisplatin was lower than 1 shot and decreased gradually. Tissue concentration of the total protein were measured in cases which could undergo hepatectomy after UFP. Total protein suspended on the lipid remained in the tissue for long term. This is a retrospective multicenter study comparing UFP therapy with sorafenib. Post-matching MST was 12 months for UFP and 7.9 months for sorafenib, further increasing the significant difference between the two groups. In conclusion, the current proof of concept study showed that UFP therapy prolonged survival than sorafenib in patients with locally progressed HCC. We show the recent result of UFP therapy for advanced hepatocellular carcinoma involving vascular invasion. 302 patients with unresectable HCC involving vascular invasion were enrolled in this study. Child P class A 201, B plus C 101. Mean diameter of tumor was 95. PVTT trunk 82, first branch 112 28 patients. There were 50 cases with extrahepatic metastasis. The evaluation was performed as follows. In efficacy, CR was 49, PR was 158 patients respectively. Response rate was 68.5%. 85 patients showed the disappearance of viable HCC. In detail, treated with HIC only 42, as conversion therapy, surgical resection, 35 cases. The cumulative survival of all patients is shown. 1-year survival rate was 63, 3-year was 31, and 5-year was 23% respectively. The median survival of these patients was 19 months. The MST was 22 months for the advanced stage case of Child-Pugh A. The MST of response case was 31 months, and the 5-year survival rate was 31%. In the effective group for UFP, the MST of 85 patients with a disappearance of viable HCC was 67 months, and the 5-year survival rate was 55%. When we achieved the cancer-free statement, we could get long prognosis. Hepatectomy could be added after UFB. The 5-year survival rate was 80%. This case was a 78-year-old male with multiple HCCs. Maximal tumor in left lobe was 147 mm in diameter, and portal vein tumor invasion. This case received surgical resection after 12 course of UFB. The patient has remained cancer-free statement for 54 months. This case was a 61-year-old male with advanced HCC. Maximum tumor in right lobe was 130 mm, and portal vein tumor invasion. His liver function was declined, and his general condition was worsening. After 6 courses of UFB, liver function improved and hepatic resection could be performed. The patient is alive without recurrence for 4 years after liver resection. Next, I will introduce the LAUNCH study. This is a comparison of lenvatinib alone and lenvatinib plus TACE for advanced HCC. Len-TACE had significantly better ORR than lenvatinib alone. Len-TACE had significantly better PFS and OS than lenvatinib alone. Combining TACE with lenvatinib improved treatment outcomes. So, combining UFP with lenvatinib may also improve results. I would like to introduce one more paper about the LEOPARD study. This study verified the usefulness of hepatic artery infusion of cisplatin in combination with lenvatinib. The therapeutic efficacy was CR 29%, PR 35%. The cumulative survival of all patients is shown. The median survival of these patients was 17.2 0.2 masses. The combination of cisplatin and lenvatinib was shown to enhance efficacy. So, combination of UFP and lenvatinib may enhance efficacy. Combining UFP with systemic chemotherapy had a significant better response rate of 82% and MST of 35 months. This case was a 24-year-old male with multiple HCC in both lobes. Total vein tumor invasion for the left branch was detected. In addition, lung metastasis was also seen. After UFP 6 course, we could achieve PR. We started lenvatinib and performed RFA to lung metastasis. After that, we performed hepatic resection. He is alive with CR for 72 months. This case was a 77-year-old male with advanced HCC. Maximum tumor diameter was 230 mm. He was treated with a combination of UFP and lenvatinib. After 10 courses of UFP, the HCC was reduced and he could perform hepatic resection. The patient is alive 32 months without recurrence. This case is a 42-year-old male with multiple HCC and lung metastasis and peritoneal dissemination. We started UFP after controlled intrahepatic lesion. We performed peritoneal seeding resection. Next, we treated lung metastasis with atezolizumab. After disappearance of lung metastasis, we performed hepatic resection and could achieve CR. He has survived 50 months without recurrence. In conclusion, UFP therapy demonstrated favorable tumor response in patients with advanced HCC. Adding conversion therapy with a goal of complete cure made long-term survival possible. Adding systemic chemotherapy to UFP further improves treatment outcomes. Thank you.
Thank you for your excellent presentation. Do you have any question and comment from audience? Please.
Yeah, thank you for wonderful presentation. I have a question. So you show the very good result, and you inject the mixture of the lipiodol and cisplatin followed by 5-FU, right?
Yeah.
And which is effective? I mean, do you confirm the accumulation of lipiodol? Because lipiodol has slightly systemic effect. So which is effective in your new FD system?
Low-dose FP regimens most effective 5-FU, I think, but UFP therapy cisplatin ischemic effect and cisplatin direct and 5-FU, all mixed. I think.
Thank you. So, in case you cannot find the no accumulation in the tumor after UFP, in that case, is that effective? You don't check the CT after injection?
Yeah, all patient after injection, CT I'll check.
So if you don't find the accumulation of lipid, but you still continue the new FP, right?
Yeah.
Oh, thank you.
Please, Dr. Nakamatsu. Oh, yes.
Okay, thank you. Thank you for your nice talk. I'm Dr. Chen Jinlin from Taiwan Hanggang Memorial Hospital. I have a question about for patient selection. Because intrahepatic artery infusion chemotherapy is only local treatment for liver tumor. So for advanced HCC in the locally in the liver, what kind of patient you prefer use the intrahepatic HAIC or some other patients use the immunotherapy? How do you choose?
Thank you. Most effective cases, I think, advanced HCC with portal vein tumor or invasion patient.
Only use the portal vein invasion for your selection criteria.
But sometimes I try huge HCC.
Okay, thank you.
Okay. I have one short question. You show the very good clinical outcomes. The UFP treatment method, what is the mechanism of your treatment? Cytotoxic chemotherapy or embolization? What is this?
I think both.
Both? But as you know, CDDP and 5FU, the cytotoxic chemotherapy, they didn't show any the positive results over the systemic treatment, the molecular target agent or immune checkpoint inhibitors. So I think you have to explain what is the mechanism of your good performance. Cytotoxic agent is working or embolization is working?
Recently, I mixed TKI, for example, lenvatinib. And
Okay.
Okay. So, thank you again. So, one of the moderator, Dr. Miyayama, has a presentation in another session and will join this session late. And I also have a presentation in another session, so I will switch place with Dr. Miyayama in the middle of the session. Please.
Okay. Thank you. I'm Juan Pang from Korea. I worked in the National Cancer Center, Korea, but recently I moved to private university hospital, Myeongji Hospital. And the next topic is TACE combined with HAIC and ICIs could be an affordable treatment option for advanced stage of HCC. Will be presented by Dr. Kondo. Dr. Kondo, please.
Thank you, Chairman, and members and guests. And this is a disclosure of my conflict of interests. Recently, the various kinds of MTA and ICI in generative HAIC could achieve the volume reduction of HCC. If we can achieve the volume reduction of HCC, ablation therapy can be carried out. The treatment efficacy for the patient with advanced stage HCC has been improved by the molecular target agent, immune checkpoint inhibitor, and radiation therapy, in addition to TACE and/or HAIC and hepatic artery infusion chemotherapy HAIC. However, the treatment efficacy for the patient with advanced stage HCC treated by a single agent has not been adequate. If the liver function reserve is poor, the treatment of HCC should be limited. Recently, the various kinds of MTA and ICI were available. However, HCC patients with good liver function reserve should be treated by them. Systemic therapies such as MTA might rapidly decrease the liver function reserve due to appetite loss and other adverse events in some patients. It is necessary to develop the treatments that could maintain the liver function reserve. I will briefly explain the classical hepatic artery infusion chemotherapy. The treatment indication of HAIC was advanced stage of HCC with vascular invasion and multiple HCC in both rows. The technical procedure includes the modification of blood flow and catheter placement and implant port. Good point of HAIC includes a sometimes effective difficult to treat HCC, such as TACE refractory multiple massive vascular invasion, and had less adverse events available in patients with low liver function reserve. Bad point of HAIC is the technical procedure of HAIC is a little bit complicated. The two representative regimens of HAIC include the 5-FU interferon and low-dose FP. Both regimens, the response rate was about 50%. Recently, we published a Day3 combined with HAIC might be an affordable treatment option for advanced stage of HCC. All patients were treated by weak embolization using hepasphere with cisplatin. After a weak Day3 procedure, we carried out catheter implantation immediately. Some patients needed gastroduodenal artery coiling and or right gastric artery coiling to avoid gastroduodenal ulcer or pancreatitis. 5 French catheter was inserted in the proper hepatic artery or targeted for a more specific hepatic artery. On day 1, we carried out weak Day3 with cisplatin. Low-dose FP was carried out 10 times for 2 weeks, followed by a rest for 4 weeks. This regimen is the course of ultra FP. This regimen was continued until the appearance of severe AE, tumor progression, or a remarkable effect of treatment, and the conversion to curative therapy such as liver resection or ablation. This slide shows the possible merit of ultra FP. The strong point of Anson PU catheter by brachial artery. It is not necessary to plant a port of reservoir in subcutaneous. It is possible to change the treatment area. It can reduce the thrombosis risk, infectious risk, and vascular occlusion risk. The strong point of low-dose FP therapy following weak embolization of HCC by using hepasphere with cisplatin. Drug delivery of cisplatin induces a partial tumor lysis, and immunogenic cell death might induce effective tumor immunity. Therefore, ultra FP might enhance the effectiveness of ICI. This slide shows the inclusion of this study. 80 patients with metastatic liver cancer, intrahepatic cholangiocarcinoma, and low-dose FP without Day3 were excluded in this study. The majority of HCC etiology was non-HBV and non-HCV-related HCC. Treatment history of HCC existed in 69 patients, including resection, TACE, ablation, and MTA. The number of patients based on the stage of the general rule for the clinical and pathological study of primary liver cancer Japan, 1, 2, 3, 4, and 4B were 0, 26, 46, 26, 22 patients, respectively. All patients of stage 2 were TACE refractory patients. The objective response rate of therapy was 74.6% and disease control rate was 89%. Tumor marker reduction was observed in 81.4%. Objective response rate in patients with macrovascular invasion was 75%. This slide shows the survival curve. Median survival time of all included HCC patients was 738 days. The MST of HCC stage based on the general rule for the clinical and pathological study of primary liver cancer 1, 2, 3, 4, and 4B was not reached 1,065, 764, 718, 280 days respectively. The MST of BCL stage A, B, C was not reached 816, 585 respectively. The MST of subclassification of BCLC with kinky criteria, stage A, B1, B2, B3, C was not reached 1065, 764, 596, 585 days respectively. The survival curve of HCC patient with or without macrovascular invasion were almost the same. The median OS of HCC patient with PVTT negative, PVTT positive was 816 days and 718 days. The treatment response of HCC patient with VP4 PVTT by ultrarapid therapy, CR, PR, SD-PD are 0511 patient respectively. The median OS of HCC patient with VP2, 3, 4 were 718, not reached 458 days respectively. Then I analyzed the change in RV score and grade after ultrarapid treatment. RV score worsened slightly after treatment. However, the frequency of patient among each RV grade didn't change significantly. Then we analyzed adverse event due to ultrarapid therapy. Grade 3-4 adverse event induced by the tumor lysis, such as AST and LT elevation, and blood bilirubin increased, gamma GTP increased, and hyperalbuminemia were temporarily observed in some patients. Moreover, the other group, Dr. Hang reported that TACE with HAIC was tolerable and led to better OS than TACE in patients with large or huge HCC, especially in those with non-smooth tumor margin or macrovascular invasion. Therefore, TACE combined with HAIC could be a affordable treatment option. Recently, many HAIC-related study reports were published in 2022 to 2023. If we searched HAIC and HCC by PubMed, we could find an increasing number of articles regarding about HCC and HAIC. Moreover, HAIC TACE combined with TKI or ICI were studied by the many groups. In TACTICS trial, TACE plus sorafenib didn't show significant OS benefit over TACE alone. However, clinical meaningful OS prolongation and significantly improved PFS was observed. TACTICS L trial investigated the efficacy and safety of TACE plus lenvatinib. Len-TACE achieved a high response rate and high complete response rate. Some groups reported the HAIC TACE combined with ICI resulted in a relatively high objective response rate. The median OS from the initial course of atezolizumab plus bevacizumab was about 13 months. However, median OS from the ultra-FP was about 37 months. These data were influenced by the selection bias. However, this data might indicate that induction therapy such as ultra-FP might prolong the OS among the HCC patients treated with ICI treatment. Then we found the OS was influenced by the control of intrahepatic lesion. The good control of intrahepatic lesion could lead to good OS. Previously, we analyzed the MDSC in HCC patients. We could clearly detect the PD-L1 positive MDSC by using molecular FACS analysis. The reduction of HCC volume might decrease the frequency of MDSC. Lower frequency of MDSC might enhance the effect of ICI. Then I would like to show you two case studies by ultrarapid therapy. The first case was an 80 years old male, and his background liver disease is a non-B, non-C, and he is an elderly patient, and he had cardiac disease, and he had a past history of AMI. His liver function reserve are Child-Pugh and RB2A. Tumor marker FP was 53.8, DCP was over 8,000. This slide shows the contrast enhanced CT before the first course of ultra-FP. 11 centimeter size, 2 nodule vascular invasion, and without lymph node distant organ metastasis. Therefore, the stage was T4 enzyme 0, stage 4A, BCLC B2. And after 3 course of ultra FP, we can achieve tumor reduction. This slide shows the treatment course and the tumor marker transition. After achievement of tumor reduction, we carried out microwave ablation. Then residual viable regions were ablated by RF therapy. We can maintain CR over 1 year. Moreover, the liver function reserve was improved during the multidisciplinary treatment. The next case was a 60-year-old male, and his background liver disease is a non-B/non-C. He had hypertension, diabetes mellitus, paroxysmal supraventricular tachycardia. His liver function reserve was Child-Pugh RB2A. Tumor marker FP 12.2, and DCP was over 60,000. This slide shows the contrast-enhanced CTP for the first course of ultra therapy. 20 cm, 10 cm, 2 cm, 3 nodule, and with portal vein tumor thrombosis, lung metastasis. Therefore, the stage was a T4N0M1 stage 4B BCLCC. After 3 courses of ultra FP, we can detect a necrosis lesion in the huge HCC, and the size of tumor was gradually decreased. The speed of tumor reduction was slow in comparison to previous case. Therefore, this patient was treated with 4 mg lenvatinib during the drug holiday of ultra FP. After achievement of enough volume reduction, RF therapy was carried out several times. Functional liver reserve could be maintained during the multidisciplinary treatment. Performance status has been good during the treatment. Here, continuing treatment so far. Therefore, this slide shows the strategy of HCC treatment and in our institute. We are pursuing the strategic potential of IBR and ICI, and addition of ablation and or systemic therapy depending on the treatment response. And maintaining not only liver reserve, but also renal function and platelet counts are important to continue the treatment of HCC. Therefore, we should consider PSE and dialysis at appropriate time point during the multidisciplinary treatment. In conclusion, ultra FP therapy could be an affordable treatment option for difficult to treat advanced stage HCC. ICI treatment might prolong OS after the control of intrahepatic lesion by using local regional therapy. This slide shows the collaborator. Thank you for your attention.
Thank you. Now, this topic is open to the audience and the floor. Is there any question and comment? Yes, please.
Yes, thank you for wonderful presentation. You also show the good outcomes from difficult patient. So I have a question. So initially you embolize the tumor and followed by cisplatin and 5FU?
Low-dose FP.
Low-dose FP, right? So if you embolize tumor first strongly and totally, there's no room to which chemotherapy works. So you told me that you perform the mild embolization.
It's a very good question. As I mentioned in this presentation, the Day test procedure is very weak, like 30% or 40% embolization. So that is the point of the good result.
So if after the embolization, if you find a residual tumor stain, but
yes.
you quit the embolization.
Yes.
Oh, okay, thank you.
Okay. And yes, please.
Thank you for the nice presentation. I'm Toshiro Tanaka from Nara Medical University. My question is, you use a HEPA-sphere, right? The HEPA-sphere can load the limited dose of the cisplatin.
Yeah.
Do you use additionally infusion of the cisplatin solution?
Sometimes I use the miriplatin now, but in this data, only the cisplatin with HEPA-sphere.
You mean miriplatin loaded by...
After the cisplatin.
Oh, okay. HEPA-sphere loaded with cisplatin, followed by miriplatin Ripaidol.
Mhm.
Okay. Thank you.
Dr. Kondo, I have a short question. You published your data recently, and that result is the first line treatment or second line treatment or third line treatment. I'm asking the indicated patient, they are treated by firstly by your method or first treatment with the TKI or immune checkpoint inhibitors, and after then progression, so you treat them.
Yeah, this study includes every patient, such as already treated by the TKI or some TACE. So it's very difficult to treat advanced stage patients.
So most patients are second line or third line treatment by your
Yes,
method.
right.
Okay, I see. Okay, thank you.
Thank you.
Now we'll move to the last topic. Current indication of TACE and combination therapy with the systemic agent for HCC will be presented by Dr. Tanaka, Toshihiro Tanaka, please.
Thank you, Chairman. It's my great honor and pleasure to talk here today. The updated BCLC criteria 2022 show the indication of our TACE is limited. Only for the patient selective access can be done. And the extensive viral disease should be treated by the systemic drugs. Then from Korea, this paper was shown in intermediate stage, CR achievement can prolong the survival by TACE, obviously different from the non-CR group. This schema suggested by Professor Kudrow shows the intermediate stage divided into 3 or 4 groups. Within up to 7 criteria, it can be achieved CR by this. 7-11 criteria it is decreasing the CR ratio, and beyond up to 11 criteria or by multiple over the tumor number over 10 can't be obtained CR. This is our data. The question is, the TACE can achieve the CR in even beyond up to 7. Our results show the CR ratio was 57% by 2 times TACE, and CR patient improved the overall survival. The predictive CR factor is up to 11, within up to 11. From this background, we suggest these are subclassification. Intermediate can be divided 3 groups, and within up to 7 or early stage, we can treat it only by TACE and can achieve the curative. And 7 to 11 curative treatment should be achieved by combination of the systemic therapy. And beyond up to 11, systemic therapy is mainly, and we combined with palliative TACE. However, for a large HCC like this, we can treat the TACE mainly. Additionally, systemic therapy also can be achieved CR. Tumor number and the tumor size is not equal. Tumor number is more important than size. This is our multivariate analysis. So the tumor diameter over 6 centimeter was not a factor of the prognosis. Tumor count is over 7. The prognosis prognosis factor in univariate analysis, but not significant in multivariate analysis. Tumor count over 11 was a significant factor in multivariate analysis. This is obviously difference between tumor number over 11 and under 11, like this. I will show two cases here. This is a huge HCC, 14 centimeter in diameter, good liver function. We firstly treated by bland TA using a gelatin particle alone, and large part of the tumor was necrosis, and followed by TACE via inferior phrenic artery and hepatic artery. And the CR was achieved. The patient survived for 7 years. In contrast, this is a patient has also has a huge HCC, and also there are multiple liver intrahepatic metastases like this. Using the same strategy, we treated this patient bland TA first, followed by TACE. However, this patient can't control by TACE. They survived only 13 months. Next, I will talk about the combination of the systemic drug and TACE. This is a TACTIC trial, TACE plus sorafenib compared with TACE alone. This study showed significantly improved the progression-free survival in TACE, the combination group. This is a TACTIC L trial, single-arm phase 2 trial, TACE combined with lenvatinib. This trial showed extremely high CR rate, 53% 4 weeks after TACE, and the best response rate was 67.7%, and the long progression-free survival. When compared with the TACTICS trial, TACE sorafenib CR rate was 28%. TACTICS L trial showed a combination with lenvatinib showed a CR rate of 53%, significantly higher. This paper showed Day3 combined with lenvatinib versus Day3 plus sorafenib. The lenvatinib combination is higher, longer overall survival and progression-free survival. This is a launch survival. Dr. Nagamatsu already shown. Even in the advanced stage, this combination shown the good result. This is a meta-analysis. Lenvatinib plus TACE was superior to the TACE alone or lenvatinib alone. This combination is a synergistic effect. The mechanism of this synergy is lenvatinib had anti-VEGF function. It can normalize the tumor vessel. Tumor vessel is structurally and functionally abnormal like this. Before TACE, lenvatinib can create a normal vascularization. This is a case. We treated 4 days, only 4 days lenvatinib. The CTHA decreased the tumor vascularity. The vascularity decreased around 42.5% by the 4 days lenvatinib administration. This is the same patient of DSA before and after lenvatinib 4 days. We can see the normalization of this precise angiography. Permeability, tumor stain was decreased. Also, the smooth and thinner hepatic artery like this, and the appearance of the tiny tumor vessel. I can say this could be the normalization by lenvatinib. We treated by TACE and achieved a good lipid accumulation. I will show the two cases. This is lenvatinib followed by TACE case, 37 millimeter. This is actually early stage HCC, but located in the hilar tumor and adjacent to the portal vein. Then we treated by TACE. Using a workstation navigation system, we treated 3 vessels by TACE, and very well accumulation of lipid, and CR was achieved. Another case is lenvatinib followed by TACE. Lenvatinib performed 4 days as well, and vascularity was decreased to 21%, and we treated by TACE. Also, we use workstation. Selective TACE was performed like this, and the CR was achieved by the contrast enhanced CT. And after this TACE, we continue the lenvatinib, low dose lenvatinib like this. And after 6 months, liver function maintained the same level, and the CR still obtained. The immune checkpoint inhibitor marker is also increased after the TACE. This is a surgical specimen. PD-1 and PD-L1 was increased after the TACE. And currently now ongoing many randomized control trial combination of immune checkpoint inhibitor and the molecular targeted agent combined with TACE. We are looking forward to these results. In summary, 7-11 criteria is useful to determine the indication of TACE. Vascular normalization by lenvatinib could be enhanced TACE efficacy, and TACE combined with TKI ICI could be the standard therapy for the intermediate stage HCC. Thank you for kind attention.
Now, this topic is open to the audience and the floor. Is there any question and comments? Yes, please.
Thank you for your nice talk. I'm Dr. Chen Junli from Taiwan. About your lens taste study, would you use the lenvatinib holiday during the TACE treatment? And how many days transgenic stop or do not need stop? Continue to use lenvatinib.
Do you mean the after TACE? Before TACE?
Before and after.
Yeah. Before TACE, we administered 4 days lenvatinib, and then with that stop, we performed the TACE. And after TACE, after the recovery of the liver function and the post-embolization syndrome, we continue the lenvatinib, low dose.
So the 4 days before TACE.
Yes.
And how many days after TACE?
How many days?
Yes.
Mean duration is around 7 days.
7 days.
To recover the liver function.
To recover the liver function.
Exactly.
Thank you.
Yes, please.
I have a quick question. So, when do you quit the lenvatinib after TACE? I mean, if you start lenvatinib before treatment for 4 days, and how many days do you give lenvatinib after treatment?
After TACE.
After TACE, yes.
It is very difficult. If we achieve the complete response, and when in case we consider the quite low risk of the recurrence, we don't use the lenvatinib actually. And if we consider the high risk of the lenvatinib recurrence, we continuously to the over several months.
Oh yeah. So when do you evaluate the CR after TACE?
Usually 1 month.
1 month.
1 month. Yes.
Thank you.
I have one short question. After TSC, do you have any criteria for starting the lenvatinib treatment? I'm saying after TSC, many patients shows the increased AST levels over 5 times, 6 times. So, however, you said you start lenvatinib median 7 days. So it is. I think it is a very short period. So, what is your tip for such the early lenvatinib treatment, or is there any other indication of your the combination treatment?
Yeah, it's a difficult question. Basically, we usually started for the completely no symptom after this. That's I mean around 7 days. However, some doctors in Japan say that more earlier study can be safe. Then we also now is 3 days or 4 days after this. Usually, in the normal course is AST level is increasing. The top level is 3 days after TACE. This is usual, and the peak out after that. Then in currently we after check make sure the peak out of the AST level, we now is started the lenvatinib. So far, that's really okay.
Sorry, I'm late because my name is Shiro Miyayama from Fukui, Japan. I'm a radiologist. I'm sorry I'm late because my schedules are double booked. I have one question for Dr. Tanaka. TACTICS-L trial, the cohort of TACTICS-L trial included many patients with BCLC-A and BCLC-B HCC within up to 7 criteria. Most patients, I think that most of such patients can be treated TACE monotherapy. Is lenvatinib truly necessary for such patients?
It is a difficult question. Yeah, to be honest, we can treat the early stage also up to 7 in patient can be treated by TACE alone. Our university data also show that is a good result for such series patient. But when we consider the for Japan or globally, the TACE level is different. TACE result is also different. When we consider about such the all over the world data, the combination could be the chance. It should be improve the total data. It's my opinion.
I'd like to ask Professor Park.
Yes.
I think that Korean IR doctors have excellent skill of TACE. So the indication of TACE monotherapy seems to be wider than that of Japan. Do you perform combination therapy, TACE and systemic therapy please mention the indication of systemic and TACE combined therapy in Korea or your institution?
Yes. In Korea, many doctors follow the Korean guidelines of hepatocellular carcinoma, and I am a leader of a Korean guideline, and the Korean guideline is based on the evidence-based guideline. So it is not practice-based, evidence-based. So we ask what is the evidence. So the modified UICC stage of Japan. We love the Japanese staging system, modified UICC. Modified UICC stage 1 and 2. That tumors could be treated by surgery or RF ablation or other local treatment. However, the modified UICC stage 2 or 3, at the case, TACE is proven the treatment modalities. Yes, survival gain and progression-free survival is proven. So the TACE is strongly recommended for such modified UICC stage 2 or 3. And after that, stage 4, at that case, first systemic treatment is the first treatment. However, many doctors tried TAC and after then systemic treatment because of tumor burden or other conditions could be improved by partial or partial treatment, palliative partial treatment with TAC. So, yeah, that's a real practice situation in Korea.
Thank you.
Thank you, Professor Tanaka. So please, let's move discussion part. 10分あるDr. Everybody, please move to stage.
Already we have the discussion. However, go ahead.
Already discussion? So, one thing. Now, the systemic therapy area, how do you think indication for TACE and HAIC? And if you have, tell me future your plan. Some control trial and so on. How about?
The advantage of new FP that it has a high response rate, move cases, achieved cancer-free statement, and long-term survival. And there is new FP has less PD patient, so it is easy to use as a first regimen. I
Thank
think.
you. Any comment?
Dr. Ubi? Yeah, can I?
Please.
Yes. You know, I'm doctor from Korea, and HAIC treatment was developed by Japan, and Japan leaded the HAIC treatment in the world. However, many Western doctors and even Korean doctors does not use HAIC treatment for advanced HCC patients because there is no randomized controlled trial data. So almost all Western doctors and some Korean doctors, the HAIC data, good data is selection bias. They say. So I hope you are very strong in the TC and HAIC and other the intravascular treatment method field. You are very strong. So I hope you have to do randomized control trial with HAIC versus other systemic treatment. Yeah. I hope so.
I hope so.
Bruce Tanaka?
Yeah, this is actually so we don't have no evidence for the HAIC, especially compared with the current standard atezolizumab or something immunotherapy. However, in a clinical practice, that obviously we do believe the HAIC should be performed because the patient is very strictly advanced, very extremely advanced, and no time to observe the response of the immunotherapy. In such cases, we choose the HAIC. Patient can agree with our opinion. But as you say, the evidence is needed.
Yes, thank you very much. Any comment? Okay. Thank you very much. And how about TACE? TACE indication.
Yeah, this is this is very complicated because we and Professor Miyama believe only TACE can treat around 100% of intermediate stage HCC. However, there are up to 7 criteria was suggested, and after the up to 7 criteria developed, so we continuously appeal the TACE result. However, there was no comparison study then acceptable especially for the hepatologist. So, however, TACE-L showed the good result even beyond up to 7. What are the good for us, TACE favor physicians? Then now we can say TACE can do the even up to 7, beyond up to 7. We can treat it by TACE with remibrutinib. That is my opinion.
Yeah, thank you very much. How about?
And I think THC and HAIC treatment, this technique depends on the doctors. So the Japanese doctor, the past years, Japanese doctors teach Korean doctor. The Korean doctors developed some skills, and so Japanese result, Korean result, and some Taiwanese result is very, very good comparing to Western result. So it's a doctor dependent result. So we need some generalization.
It's a big problem for us.
Yes, please.
I'm B. Zhang from Taiwan. I'm an interventional radiologist, and we have done the TACE, STEP TACE, HAIC, and EGM90. But nowadays, we are having the AA, the atazolizumab, combined with all kinds of treatment because of the reimbursement in Taiwan. So how about your experience about combine the immunotherapy, TKI, and local regional therapy? And is there any considerations we should be aware, because this is totally different treatment as only TKI?
Yeah, that is a very promising strategy. Already, Emerald, as you know, Emerald 1 showed significantly improved the progression-free survival compared with TACE, Durvalumab, and bevacizumab compared with the TACE alone group. So the next near future, we are waiting for the result of the LEAP 012. That will be the TACE combined with remibrutinib and another video. That is in the future, the evidence will be coming, and we can do the TACE combined with immunotherapy for the more intermediate stage or advanced stage patients.
Do you remember the TACE plus sorafenib trial in far advanced stage HCC? The study failed. However, the sub-analysis of that study, small tumor growth less than 5 centimeter, that combination treatment shows a better outcome. So such a combination is not the almighty. So we have to find some good indication patient. So large tumor and far advanced stage patient is not no good indication for combination treatment. It's my opinion.
Okay. We have discussed in this seminar session the current status and position of TACE and HAIC in the HCC treatment. TACE and HAIC still play an important role in the HCC treatment despite of advancement of systemic therapy. As Professor Park mentioned, techniques of TACE and HAIC are very important to improve the outcomes of the treatment. Additionally, the combination of TACE, HAIC, and systemic therapy is a novel promising treatment strategy. So we should establish the most effective combination regimen and good candidate for such combination therapy. We believe that I believe that TACE and HAIC has strong potential to cure small to medium size or advanced HCC. Thank you very much for your coming. Thank you.
Thank you. Now we have closed this session. Thank you.
Thank you. Thank you.
Thank you very much, speakers and moderators. The next session will start at 3:30 p.m.